is about male infertility. To start with, we have to know about the physiology of male reproduction. The physiology of male reproduction, including 3 steps: number 1, sperm production; number 2, sperm transport; and number 3, sperm deposition into the genital tract of the female. Number 1, sperm production or synthesis, a process called spermatogenesis. The process of spermatogenesis started from the hypothalamus. The hypothalamus releases gonadotrophin-releasing hormone, and this gonadotrophin-releasing hormone acts on the anterior pituitary, which will in turn secrete both FSH and LH. These hormones, FSH and LH, act on the testis. In the testis, there are 2 types of cells: Sertoli cell, which are found inside the lumen of seminiferous tubules and responsible for the production of the sperm, and there are the other cells called Leydig cell, which are supporting cells outside the lumen. So FSH will act on the Sertoli cell to promote the synthesis of the sperm or to promote spermatogenesis, while LH acts on Leydig cell, and this cell will produce or secrete testosterone, which help in the process of spermatogenesis. And the spermatogenesis take about 72 days to 84 days to be completed. After sperm synthesis or spermatogenesis, the second process, which is sperm transport. The transport of the sperm occurs through a series of channels from the testis to the outside. These include the retitestis, the efferent ductules, the epididymis, the vas deferens, the main ejaculatory duct, and to the outside of the body. This animation shows the transport of the sperm from the testis to the epididymis to the vas deferens, and then joined by a secretion from the prostate gland and seminal vesicle to the main ejaculatory duct and to the outside. After sperm transport, the third process started, which is sperm deposition. And this sperm deposition in the genital tract of the female depends on the regularity and timing of intercourse in relation to the time of ovulation of the woman, and also depend on the quality of the sperm regarding motility and function and morphology. According to the physiology, we can divide the causes of male infertility into the following. Number 1, pretesticular, which means the pathology is in the hypothalamus and pituitary gland. Number 2, testicular, which means inside the lumen of seminiferous tubules and in the cell like Sertoli or Leydig cell. And number 3, post-testicular, which the pathology either in the transfer of the sperm or in the deposition of the sperm to the genital tract. And we will discuss each separately. Regarding pretesticular cause, as we said, the cause lies either in the hypothalamus or in the pituitary gland. In the hypothalamus, example, Kalman syndrome. In the pituitary, example, tumor of pituitary gland. Number 2, exogenous hormone, example, androgen, those athletic patients who take androgen or steroid. Number 3, thyroid disorder, especially hypothyroidism. Number 4, hyperprolactinemia, and this in addition to infertility, the patient may present it with a decreased libido. And the third causes in the pretesticular etiology is growth hormone or isolated growth hormone deficiency. Regarding testicular cause, the following are responsible for infertility. Number 1, either chromosomal, example, Klinefelter syndrome. Number 2, gonadotoxin like drugs and radiation. Number 3, systemic disease like liver failure or renal failure. Number 4, any testicular injury like trauma to the testis, mumps, which occur in the childhood, especially if involve the testis, called mumps orchitis. Any torsion of the testis, and any surgery like inguinal or femoral hernia or direct surgery to the testis. Number 5, cryptorchidism, and by cryptorchidism we mean undescended testis, and this is very important. We should know it because if it is found in childhood, it should be corrected within 2 years, maximum 3 years. If it is remained more than this time, it lead to infertility and subsequently lead to malignancy. So it should be corrected within 2 years of life. Number 6, varicocele, and by varicocele we mean dilatation of the pampaniform plexus of the spermatic cord, and this dilatation of the vein lead to an increase in the temperature of the testis and subsequently asthenospermia. Number 7, idiopathic or genetic causes. Regarding post-testicular causes of male infertility, we said either disorder of sperm transport or disorder of sperm deposition. With regard to disorder of sperm transport, there will be either congenital blockage of the channel responsible for the transfer of the sperm, like cystic fibrosis, or acquired blockage. And acquired blockage occur in or following surgery for hernia, vasectomy, and even bacterial infection due to sexually transmitted disease. Number 3, functional blockage due to sympathetic nerve injury or pharmacological. Disorder of sperm deposition, either disorder of sperm motility and function, defect in the sperm motility, asthenospermia, oligospermia, or abnormal morphology, or disorder of coitus, and this is maybe due to the frequency of coitus, and at least should be twice per week to achieve pregnancy. Timing of coitus in relation to the time of ovulation. And number 3, congenital anomaly in the penis like hypospadias or epispadias. And number 4, retrograde ejaculation, which occur in long-standing diabetes. Now, how we manage infertile male or infertility due to male causes? And as you know, management including history, examination, and investigation. Regarding history taking, we should take developmental history. We should ask about if there is undescended testis, puberty, is it normal or not, any loss of body hair. Number 2, we should ask about infection, especially mumps in childhood, especially if it involves the testis. We should ask about sexual transmitted disease like gonorrhea. And we should ask about history of prostatitis. Surgical history, we ask about any surgery for hernia, like inguinal hernia or femoral hernia, and any vasectomy. Drug and environmental, and the important drug we should ask include the following: sulfasalazine, methotrexate, colchicine therapy. All these lead to impaired spermatogenesis. Also, we should ask history of testosterone injection in athletic patient, because this will lead to pituitary suppression. Also, we should ask about common drug like cimetidine, tegamate, which is used as antacid, and spironolactone, which is diuretic. Both of these, they have anti-androgenic properties and lead to infertility. We should ask about alpha blocker, antidepressant, and phenothiazine. And we should ask also about beta blocker, thiazide diuretic, and metoclopramide, which lead to hyperprolactinemia. All these important regarding history taking in patient with male infertility. Also alcohol, smoking, because smoking affect fertility. A drug which cause hyperprolactinemia, radiation, and exposure to heat environment. Number 5, we ask about sexual history, about libido, frequency of intercourse, and timing of intercourse in relation to the time of ovulation. And as you know, the oocytes remain in the genital tract for just 24 hours. Also, previous fertility assessment and treatment, and if the patient have any chronic medical disease. Regarding physical examination, we should examine the penis, location of urethral meatus, palpation of the testis and size of the testis, presence and consistency of the vas deferens and epididymis, presence of secondary sexual character, presence of hair, breast development, digital rectal examination for the prostate gland. Now, what important investigation we do it for infertile men? The basic investigation and initial investigation is semen analysis, and subsequently we may need to do hormone testing, testicular ultrasound, testicular biopsy, and genetic study. So all these according to the patient, but the initial step is semen analysis. The semen fluid analysis, we ask the patient to abstinence from intercourse more than 2 days, not less than 2 days and not more than 7 days. So between 2 to 7 days should be abstinence, not less than 2 days and not more than 7 days. We ask the patient to collect the sample at the laboratory better and send it immediately to the laboratory to be examined. And also, we should ask the patient that the first part of the ejaculate is the richest in the sperm. The normal parameter, volume 1.5 ml, the sperm concentration 15 million per ml, total motility 40%, progressive motility 32%, normal morphology should be at least 4%. According to semen analysis, any abnormality, we can find it and we describe it. Now, the term describe male infertility include the following. Oligospermia if the sperm count less than 15 million per ml. Astenospermia if a reduction in the motility of the sperm less than 32%. Teratospermia mean reduce the normal morphology of the sperm less than 4%. Azoospermia mean there is no sperm in the ejaculate, 0. Aspermia mean no ejaculate. These are the main terms used to describe male infertility. If the semen analysis revealed something abnormal like azoospermia, we should do endocrine evaluation. And the endocrine evaluation includes serum, FSH, LH, and prolactin. And by this, we can see the cause of azoospermia or severe oligoastenospermia. If FSH, LH is very low, they are called hypogonadotrophic hypogonadism, like Kalman syndrome. If they are high, it means that the testis is not working, and this is example in Klinefelter syndrome. If prolactin is elevated, it is lead to decreased libido and male infertility. Also, sometimes we do serum testosterone, thyroid function test, and serum estradiol. If the patient have azoospermia, we may have to do genetic study, karyotype to the patient to see whether there is Y chromosome deletion or to diagnose Klinefelter syndrome. Number 4, ultrasound Doppler study for the presence and size of the testis and for the presence of varicocele and for grading of varicocele. Number 5, testicular biopsy, and this testicular biopsy we take sample from the testis and examine under microscope to see whether there is a spermatogenesis or not. And this helps to differentiate between two types of azoospermia. There are two types of azoospermia, either obstructive and non-obstructive. Obstructive mean there is normal synthesis of the sperm inside the testis, but there is a blockage of the channel responsible for transfer of the sperm to the outside. But in non-obstructive azoospermia, there is no sperm at all. So obstructive azoospermia can have a child by IVF and non-obstructive cannot. Now, the treatment of male infertility. The only patient who benefit from treatment are those with hypogonadotrophic hypogonadism, a pre-testicular lesion. They have low FSH and LH and low testosterone. And example of those patients are Kalman syndrome, pituitary tumor, steroid abuse, and testosterone replacement therapy. So those patients, they have low FSH and LH. So if we give them exogenous FSH and LH, we will achieve our therapeutic goal. The classic treatment for male infertility with hypogonadotrophic hypogonadism is urinary HCG pregnil 1000 to 2000 intramuscularly twice or 3 times per week. In addition, we use purified FSH like gonal F 75 to 150 international unit 3 times per week. The treatment of this patient should be continue for 3 months because the process of spermatogenesis take about 2.5 months. After that, we do semen analysis and see the response to the treatment. This is the only specific treatment. Other treatment is regarded as empirical treatment. Example of empirical treatment, number 2 is antioxidant. Why we use antioxidant? Patient or infertile male, they found they have increase in the level of oxidative stress or reactive oxygen species. And this reactive oxygen species or oxidative stress will cause cell damage and DNA damage of the sperm and lead to astenospermia. So supplement with antioxidant may help to reduce cell damage and help to increase in the motility of the sperm. Example of these antioxidants: L-carnitine, lycopene, zinc, and coenzyme 10. Other empirical treatment, number 3, aromatase inhibitor. Example, letrozole 2.5 mg twice daily. This is especially useful in obese male with oligospermia. Number 4, bromocriptine in patient with hyperprolactinemia. And number 5, surgery in case of varicocele, and this is indicated in severe varicocele with reverse flow on Doppler ultrasound. We ask patient to do Doppler ultrasound and to do Valsalva maneuver. If there is reverse flow, it may be indicated for surgery. And lastly, the majority of those patients with male infertility are treated by assisted reproduction either by intrauterine insemination or IVF. Thank you.